Our last class will be on next Saturday. That will be the embryonal tumors. And tomorrow, Dr. Gaurav is going to cover the ependymomas and the pediatric gliomas, both high grade and low grade. Yeah, okay. We start now. I'm just going to show you some unusual cases that we have seen in last few years. Mostly glioneuronal and one or two other tumors. We were really short of time this week, but I have, even though I took out the cases, I was unable to, picture them. Then even though when I pictured them, today I forgot to transfer them in my stick, and they are in the hospital. So I won't be able to show you today. Maybe with the embryonal tumor cases, I will show you one or two more cases. So this is the first case. This was a 28-year-old man who presented with seizures. So he had his first seizures 6 months back. And after that, since he was symptomless and responded to the anti-epileptic drugs, he didn't do anything. But then he had another seizure, following which MRI was done. And his right temporal lobe showed an SOL. So this is an SOL tumor which is cystic with a solid nodule. So can you write the differential on this radiology? I told you the differential in the last one of the classes. Can you write the answer? So you have a tumor which is like this. Your differential are ganglioglioma, pilocytic astrocytoma, and if it is in the posterior fossa, then hemangioblastoma is another differential. So this is a cystic tumor with solid nodule, and that too in the temporal lobe. That is a very common site for many of the glioneuronal tumors. So in CNS tumors, we usually get multiple pits. We don't get en bloc resections. We get multiple bits. So in this, at this par, you can make out that there are blood vessels which are surrounded by lymphocytes, and there are foci of calcification. Lot of these blue dots that you are seeing. So this is perivascular lymphocytic infiltrate, and lymphocytes are also seen scattered in the tumor. Then there are these bigger cells or ganglion-looking cells, and then there are these glial cells. These are glial cells. These are glial cell clusters. These are glial. And so this is a glioneuronal tumor. You see the hyper, these are the neurons. When you see neurons like this, you should make an attempt to look for multinucleated, binucleated forms. So here there is binucleated, another binucleated form. You have lymphocytes infiltrating the stroma. This is glial tumor areas. Then there are areas of calcification. And this calcification, if you see, some of this calcification is around the neurons. This is around the neurons. New N, if you see, is not marking any of those ganglions. So making them as neoplastic ganglion cells. And these neurons are having a feathery positivity on CD34. They are the neoplastic or dysplastic neurons. And many of these so-called ganglion look-like cells are actually GFAP positive. So they were the gemestrocytic astrocytes. So which marker would you like to do now? Answer. Cannot wait so long. So you will do BRAF V600E, which is positive in this case. So what is the diagnosis? You can do reticulin, which will be rich in this. So this is a diagnosis. This is ganglioglioma, classical ganglioglioma. Yes, this is classical ganglioglioma. So case number 2 is 6-year-old boy with headache and seizures. And when his MRI was done, it showed cortical, predominantly cortical area, tumor and in the occipital lobe. This is the picture or histomorphology. A very myxoidy, mucoidy background in which you can see these cords of oligodendro-like cells, and then these are these little bigger cells or the neurons. These are very mucoidy background in which you are seeing these small cells. Again, this is almost looking like oligodendroglioma here. Clear cells, and then there are certain larger cells. These are the larger cells. These are the floating neurons. And this is an NFP to highlight the neurons. So what is it? This is a DNET. This is DNET. You know, you have these mucoidy background, small cells, many places they are in these cords. Cord जैसे बना है ना ये, and in between are these bigger cells floating. Cortical lesion, presenting with seizures. All these cells are, if I tell you this is synaptophysin, highlighting the neurons, the other cells are synaptophysin negative. So this makes it DNET. This embryoblastic neuroepithelial tumor. This is a 25-year-old male who presented with headache and seizures. Please note, majority of glioneuronal tumor present with seizures. There is a cystic lesion involving the temporal lobe near the ventricle. With peripheral enhancement. And this is the microscopy. You have these hyalinized blood vessels forming the core of the papillae, which are covered by these small cells. And in between there are also similar cells which are little larger. So a papillary configuration, which on IHC is IDH negative, GFAP positive, more on the cells around these blood vessels. ATRX is retained, and the cells intervening, the cells in these areas are new and positive. So what is this? CD34 also is highlighting some of these cells and also the blood vessels. Key 67 is really low. So what is this? This is papillary glioneuronal tumor, WHO grade 1. Okay. This one is a case which was referred to us from outside, but I don't exactly remember the history, but it was an adult and who presented, whose specimen was sent to the lab saying that this is a likely a high-grade glioma. And we don't have the radiology, but the picture show there multiple bits were sent, and it showed areas which are looking like oligo, but then area which are looking like, you know, that papillary glioneuronal like areas of education. Here again, you know, you have those the glioneuronal or rosette forming like neuroepithelial tumor like areas. And here it is looking like a typical glial tumor. Here microcyst with the small cells. Similar areas, some hyalinized blood vessels. And then this is almost looking like a neurocytoma like area. You have these neuropil A, nuclear neuropils, and you have these cells with clear cytoplasm. भगवान, एक बात बताओ, मैं ATRT तो दिखाई नहीं रही. आज की क्लास थी ग्लायोन्यूरोनल ट्यूमर पे, सो थिंक अबाउट ग्लायोन्यूरोनल फर्स्ट. ATRT तो अभी पढ़ाया ही नहीं है, कैसे दिखाएंगे? So this is a normal surrounding brain which was included in the biopsy, and this one had these nodules formation, you know, like you get those what is that tumor we call it, the एक नया एंटिटी डाला है ना, नोड्यूलर न्यूरोएपिथेलियल ट्यूमर विद क्लियर सेल, something like that, almost like neurocyte collections. This is almost looking like oligodendroglial like area. Again, this is looking like a papillary glioneuronal tumor, you know, hyalinized blood vessels which are surrounded by the small cells. This area is looking like a neuroepithelial tumor with hyalinized blood vessels. So when we did IHC, so this is the GFAP. If you see, the cells surrounding these blood vessels are GFAP positive, but in between these cells are GFAP negative. Synaptophysin showed that these nodules were strongly synaptophysin positive, and the intervening cells were patchy positive or weakly positive. And many of the intervening cells are NUN positive. And in certain areas, the NUN positivity, especially those which were looking like neurocytoma-like areas, they were showing more NUN positivity. So they were a little more mature neuroepithelial cells. That is, they were neurocytes. From neuroblasts, they become neurocytes. So they were neurocytes. Neuroblasts are new and negative, but neurocytes of neurocytoma or of any other neuroepithelial tumor are new and positive. And the key index is really low. So, Gaurav, how will we report this? How should we report this tumor? What is your opinion? This case came before you joined us. I just called it, I thought this is showing glial differentiation and different areas were showing all types of neuronal differentiation, or like areas which were looking like rosette forming glioneuronal tumor, areas which were looking like that nodule forming neuroglial tumor, and area looking like papillary glioneuronal tumor. So I simply called it a mixed glioneuronal tumor, grade 1. How would you have reported this?
Yes, ma'am, definitely it's a difficult one.
इसको देखेंगे कल फिर से
Yes,
निकाल
ma'am.
के मैं
As
देख लूंगा।
Anil said in last lecture, also all the glioneuronal tumors are basically more or less show similar kind of morphology. So there might be some overlapping in majority of the cases. So it's difficult to see exclusively one type of typical kind of morphology in a particular tumor. So it's always the best fitting possibility only.
But in this, no, I saw area like neurocytoma. I saw area like, as I have shown you so many pictures I have put. I saw areas like papillary glioneuronal, areas like rosette forming glioneuronal, and there were certain areas which were really definitely, if only a biopsy would have come from that area, that was looking like a glial component, like you see in a grade 2 glioma. So I called it a mixed glioneuronal tumor, and I did not put a grade to this tumor because I wasn't sure how this should be graded. It was some years back, so that time the new concept were also not in, or
What
I
was
was
the
not.
BRAF status, ma'am, in this case?
I think we did. If we have not done, I will find out.
We must relook at this case and get the markers which are now available with us.
Yes. So this was to highlight that you may see a mixture of, or there, as Dr. Anila showed you a long list of glioneuronal tumor. You in a single tumor can see all kind of morphology, and at that time I think the molecular will help, and also we must do at least a BRAF V600E on this. I think I must have done it or got it done from somewhere at that time. Maybe I did not have it. So I will update you on this. But you can get all the mixture in a single specimen. So at that time, you can simply call it a mixed glioneuronal tumor. Coming to the next case, this was a 12-year-old with headache and vomiting. So this is his radiology. You can see there is a tumor in the lateral ventricle. This is a tumor, big tumor, which is which shows, I am told, radiologically showing areas of hemorrhage. This is lateral ventricle near the foramen Monroe. So as was seen on radiology, there is extensive hemorrhage. And the tumor showed, see, hemorrhage, and this is full of these pink cells with large nucleus, very glassy cytoplasm, and a very distinct nucleolus. See the higher part. ये तो सबको आना चाहिए. लिखो भाई जल्दी से response. Glassy cytoplasm, large nucleus, prominent nucleolus, tumor in the lateral ventricle in a child. And these tumor also have both glial and neuronal. Yes. This is Sega. This is the classical book picture morphology that you see. Extensive hemorrhage. It presented because it has hemorrhage. That is the reason why Sega has an acute manifestation sometimes, because it can show extensive hemorrhage. So these are mixed glioneuronal phenotype, variable GFAP expression, shows intense reactivity of S100 and shows beta tubulin, synaptophysin or focal neuron positivity, and can also show neuronal stem cell markers like nesting and SOX2 positivity. So this is Sega. As you must know, as was told to you, that Sega is associated with tuberous sclerosis. Okay, so this was a 51-year-old woman who had a lateral ventricle tumor in 2009, which was diagnosed as pilocytic astrocytoma. Now has a recurrence in the lateral ventricle again with extension into the third ventricle and extensive involvement of the adjacent parenchyma. So we had lot of tissue which was sent to us. This tumor again came in, I think, 2014 or so, no, 15 or 16. At that time I had just joined fMRI. So as at this power, you can make out there is lobules and lobules of the pattern is very lobular. This is one such lobule, and when you see there are large cells, and then there are areas which show very glial morphology, and then there are these clusters of these smaller cells. These are looking glial, and these cells are looking like primitive cells. These are looking like neuronal with very prominent nucleoli. There are some mitosis also. Many areas shows very marked vacuolation. This is an area which is looking like, which is full of these primitive neuroblast-like cells. And these are those large neuronal cells with inclusions. Some EGB-like bodies were there. And here you can see the nuclear character of all these cells, which were small to these large, is almost same, but except for the size, the chromatin character is almost same. These are clusters of these neuronal cells which are in different stages of development, maturation. And there is a glial matrix in the background. In areas, it is almost hyponuclear, very few nuclei. Only the neuropil is there. गौरव, तुमने देखा था ये वाला केस? ये भी तुम्हारे से पहले से है. अब this area, हाँ, नहीं देखा?
No.
ये खुदाई में निकला है. This is almost giving an impression of a neurocytoma, clear cells but the cells are little larger. Some of them are very big. And here at the lower, you can see, these are these lobules which are made up of these neurocyte or large ganglionic cells. So this is the IHC. All the big cells are chromogranin positive. And the areas which were strongly GFAP positive. Then there are areas which are GFAP negative. Again, those areas which were GFAP positive are vimentin positive, and those areas which were negative are also vimentin negative. Nguyen is marking the small cells and the large cells, and making that they are little mature neuronal cells. Everywhere, all these cells were Nguyen positive. I have not included all but I think basically this is what is going to give you a. So what will you call this tumor? Kanchan Vinayak Joshi, you are excellent. Yes, it is a ganglioneurocytoma. Kanchan, where are you from? Oh, excellent. So this is a ganglioneurocytoma. Coming to next case. This is a 54-year-old frontotemporal lobe tumor. So this is different, okay? So here at this part, you can see there is this nodule which is different from this rest of the tumor. So this tumor, this is a small round cell tumor, and this tumor is looking at this power itself is a glial tumor with some lot of tumor giant cells. This is the glial area with a marked endothelial proliferation, isn't it? So this is the glial area, a tumor giant cells. And this is the focus of the round cells and with brisk mitosis. At this part, you can make out this is looking like what we call it as a neuroendocrine cells. On GFAP, that area, round cell area cells are GFAP negative. They are synaptopositive, and the glial area are showing very focal GFAP synaptopositive, predominantly negative. And vimentin positivity, this is also a very old case. You can see that the round cell areas are vimentin negative and the glial areas are vimentin strong positive. P53 is mutant both in the round cell area as well as in the glial area. So what is this? Bolo bolo. Dekho, a glial tumor with the P53 mutation with endothelial proliferation has to be GBM. isn't it? And with that, you have a focus of PNET. Yes. So usually a GBM with peanut-like area is like this morphology, that you will have a frank GBM and you will have an area which is like peanut. Yes, sometimes I am told that you can have a predominantly small peanut-like GBM, but they are very rare. In my experience, I have seen maybe one or two. But majority of cases, when you have a peanut-like focus in a frank GBM, that is the usual manifestation of GBM with peanut. So I do have all type of neurocytomas, intraventricular and extraventricular, atypical. I did select them, but forgot to copy them. I will show you in some other time. But these are some of the neuroepithelial tumor that we have in our records, which I have shown. Okay, questions? We do see, because but then our is a very active neuro center, more active even than AIMS. So we do get, I have seen almost each and every type of tumor that is described in WHO. So we do get, but neurocytomas are common. I'm sorry, I missed those. I had taken out all types. And neurocytomas, gangliogliomas are commonly seen. And Gaurav, we have seen 2 or 3 cases of papillary glioneuronal tumor.
Yes, ma'am. We have seen 2 cases of papillary glioneuronal tumor
and one
rosette
case of
forming
rosette forming, you know. We have seen this, and one leptomeningeal glioneuronal tumor I saw before Gaurav joined us. So yes, we have seen almost all type, but the ganglioglioma are quite common, and the neurocytomas are quite common. Neurocytomas are, when we did not have IDH, that time they were very often mistaken for oligo. And because you see, oligodendrogliomas can be synaptophysin positive. So but they are patchy positive, not like neurocytoma where each and every cell is synaptophysin positive. And usually it happens that in the problem with the neural cases is that you many times get very small biopsies. And in that, if one area is negative, other area is positive, then you make a mistake. So radiology, radiological information, and speaking to the neurosurgeon is very important. Most of the neurocytomas are intraventricular, so and oligodendroglioma don't occur in the intraventricle. So and then neurocytoma usually occur in a younger age, and we don't diagnose oligodendrogliomas in children. So if it is a child with a looking like an oligodendroglioma, and you think twice before you call it. Having a radiological information and the talking to the neurosurgeon is very important in neuropathology. More than me, Gaurav is very actively involved. He goes down to the radiology. Our radiology boss comes up, and we every week discuss each and every case. before we give a diagnosis. That is what modern medicine is about. Don't hesitate to talk to your radiological colleague and your neurosurgeons. Not only neurosurgeon, whatever your gastroenterologist, oncosurgeon, everyone, you must speak to them. Excellent, Kanchan. Good, you are learning. I also learned nephropathology because my husband is a nephrologist. But I don't practice nephropathology anymore. Okay, then. Thank you.